we're a long way from having both the experience and the evidence base in which to say we know what the state of the art of patient involvement or patient engagement is. But I'm happy to talk about it because it's something that I'm pretty passionate about. So in about 18 minutes, what I hope to do is briefly describe one experience that I've personally had with patients on dialysis and their caregivers and the clinicians who look after them in determining their top 10 research priorities. I'm going to reflect on some of the lessons I personally learned and then just sort of say some things about related to patient involvement and research that I think are worthwhile thinking about. I noticed in yesterday's program you had a whole session on this, so I'm slightly worried that what I'm going to say is not going to add anything and might even reveal my ignorance. So my perspective is actually as an enthusiastic amateur. I'm kind of a old guy that's been around the block for a while, both as a clinician and a researcher. And it's really only in the last 3 or 4 years that I've personally started to become quite interested in how we do involve patients in research. I think I'll go over this slide very briefly, but why involve patients in research priority setting? I mean, the second point just seems to me so obvious. I mean, they're the people with the disease. They're the people that we are offering to do things with and to in the healthcare system, and why the hell wouldn't they be involved in setting research priorities? Because they live with the disease, they also might identify research priorities that are quite different from people than researchers, and they might have insights into the importance of outcome measures that might be different from researchers. So this title is Why Involve Patients in Research Priority Setting, but I think the broader thing could be why involve patients in all aspects of research. It just seems to me the right thing to do. If any of you follow Healthy Debate, I just posted an opinion piece today. I'd love your comments on it if you have the time, in which I've argued that for large clinical trials that are funded in this country, I mean the really large ones that cost millions of dollars per year, I actually think that patients and the public should largely be the ones that decide which ones we do. I think we as scientists should be the ones that figure out whether the science is good enough and meets a bar. But then I think beyond that, then I think there's an argument to be made for patients and the public to be maybe not alone, but certainly playing a very major role in that. So here's the one example, and this slide summarizes 1 year of work. We used the methodology of the James Lind Alliance, so if any of you are interested in patient involvement in priority setting and research, the JLA, which is out in the UK, if you Google James Lind Alliance, you'll get their website. They got a lot of terrific stuff on there, and they've got a lot of experience doing this. So basically, the purpose of this project was to bring patients on dialysis, their caregivers, and the clinicians who look after them, and clinicians writ broad, pharmacists, social workers, nurses, docs, together, and to identify from their point of view what are the top 10 research priorities. And the JLA process is basically establish a steering group. We had, I think, 11 people. We literally had a teleconference for 1 hour every 2 weeks for a year. And the people were, I'll introduce them to you in a second, they were from across the country. We identified and involved potential partners, for example, the Kidney Foundation of Canada. And we largely used a website that we tried to publicize as much as we could for people to log on and give us their research priorities. Because we thought frail elderly people on dialysis would be less likely to go on a website than those of us in this room, we also, in a subset of dialysis units, actually handed out paper-based versions of the form. And in the end, we had 323 respondents from across the country. We can talk in the discussion whether that's a lot or not, but they actually each had a lot to say because those 323 respondents suggested 1,820 potential research questions. I mean, many of them were similar, but that's how many came through. We then had a process where the steering committee refined those questions into a short list of 30. And then we had a one-day workshop at the Lee Cushing Knowledge Institute at St. Michael's where we brought people from across the country who were on dialysis, caregivers, and clinicians, and together they came up with the top 10. There's a steering group. The researchers in it are Brendan Himmelgard and Braden Manns, two nephrologists from Calgary. But more than half of the steering group were actually people on dialysis or caregivers. And we had people from Dartmouth, Nova Scotia to Whitehorse in the Yukon participating. There's the picture of the group in at the Li Ka-shing, the day-long workshop. You can see the gentleman on the bottom right, this person on dialysis, holding on to his walker, got a bandage on, pretty frail. I'm forever grateful for him for coming. His son is actually standing not too far from him, so his caregiver came as well. But he actually had to leave at 3 o'clock in the afternoon just because he was so tired and it was so emotionally draining, but participated until then. And then relevant to this group, one of the things that we did badly was actually engage many people like him. I think one of the challenges, especially for a group like yours, is how do you engage the really frail and the elderly and the quite ill. There's a sort of couple pictures of the folks just, one of these people is a caregiver. Her mom had died on dialysis a year ago, a dialysis nurse. We used actually cards to help sort of prioritize, bring the top 30 down to 10. There's a patient on dialysis to the left and her daughter caregiver. Gentleman in the middle is an elderly person on dialysis with his wife beside him, and the far side is a vascular access nurse. And here, the purpose of this isn't to talk about the top 10 in dialysis, but just to give you a sense of the flavor of the top 10 research questions that came up. These were in order. What's the best ways of enhancing communications among health professionals, patients? How do the different dialysis modalities compare to each other in clinically important outcomes? What the hell can we do about itching, which is driving me crazy? What's the best strategy to increase kidney transplantation? What are the psychological and social impact of kidney failure on patients and their families? What are the best ways to promote heart health? What's the impact of dietary restriction, again, on important outcomes, including quality of life? What are the best way to manage an array of symptoms associated with the dialysis treatment? Depression. And then what are the best facts or access options in hemodialysis? So you can see a pretty broad array of questions. So my reflection on the process, I actually just realized that that's probably not worth it. If I had the full slide thing up, these would come out one at a time. But number one was, it was a lot of fun. It was probably research-wise the most fun thing I've done in 5 or 6 years. But it was a lot of work. We spent a year doing this. So this is not something, if you do something like this, that you take lightly. And I'm forever grateful, particularly to the patients who actually, didn't get any money for this and spent a lot of teleconferences and came to Toronto on this with us. I thought the different backgrounds of the people complemented each other very well. I was very nervous when we had the face-to-face meeting that the patients and the clinicians would kind of somehow be in tension, but actually it was very respectful and it was great. And I think it's better actually bringing them together than having patients go off in their own corner and clinicians go off on their own corner. It's not an exact science, and I'm sure if we did this again with a different group, we'd get a slightly different top 10. We did, unfortunately, older people, frail folks, and Aboriginal people were underrepresented in our group. And the research priorities are substantially different, actually, than those that are currently studied in dialysis. And Braden, there's a guy by the name of Min Jun in Calgary who's a, how the heck do I get, where's my slides not working now? Okay. Min did can someone help me with the technical aspects? Yep. Min did a survey, actually, of recently published studies in nephrology journals on dialysis, recently funded grants.
It's working for me.
Okay. Thank you.
I don't know what you pressed. You probably pressed that.
I was pressing this one.
Don't press that.
Okay. How do we get down to the next slide?
Just blacked it out, so.
Okay, perfect.
Okay.
Thanks. Thank you. So he basically looked at published studies in the medical literature on dialysis, registered trials in the international RCT registries, and dialysis studies that are being funded. And you can see that the vast majority of studies either being done or published in dialysis do not cover the top 10. So the top 10 are from the left, and then the ones that are not in the top 10 are on the far right. And so you can see things like itching, communication, virtually not studied at all. And so I'm not arguing that patients and their clinicians should entirely drive the whole research agenda, but I am suggesting the research agenda should be a little better aligned than it currently is. Let me just, because of time, push on to the final part of my talk, which is really the top 10 things about some things to think about that I would encourage. I mean, my sense is that you folks are ahead of the curve involving patients in your work compared to most folks, but a few things. I mean, I think one should only do it if one's serious about it. There's nothing worse than engaging people and then actually not taking them seriously. So I don't think that's an issue for you. I've already mentioned the time and effort. You know, I think one size does not fit all. And, you know, you need to be strategic. These things do take resources and they take time. And I don't think you need to involve patients in absolutely everything. And I think the patients would tell you that probably too. Actually, an interesting way of thinking about the research that I think is helpful is to think of the preparatory phases, which is like what research should we do, preparing for the research, the execution, how do we do it, what patients do we include, et cetera, and then the translation, how do we make sure that the results are understood by the people this is meant to affect. Like all things in life, there are pros and cons of this, and sometimes it works well and sometimes it doesn't. And you know, many of us in this room prescribe drugs, none of which don't have side effects. So, you know, I don't see the fact that this ain't easy and that sometimes it ain't going to go real well as a reason not to do it. I do think that there's lots of sort of feedback and training needed, actually on both sides. I think some of the feedback from patients around sometimes scientists just sort of ignore them when they're in the room with them. Similarly, I think there sometimes needs to be feedback to patients about, you know, what are the things that you can bring that are really useful? And I'm not going to give details because I don't want to sort of be clear about who the individual was, but I was at a strategic planning exercise recently where a patient got up and for 15 minutes told this story that was sort of an interesting story, but frankly was kind of irrelevant to why we were all there. And I felt sorry for him, and I felt actually that he probably hadn't been well prepped to sort of say, like, this is what we're here for, and this is how your stories could be helpful. So I think there's training on both sides of the agenda. Now I'm having problems as well. One more time? There we go. The other thing to remember is that some patient groups have been doing this for a long time. I mean, HIV for probably 20, 25 years. The Aboriginal community, I think, is starting to get very expert at this. And when I look at the literature on this, much of the literature comes from what I would call disadvantaged groups, pediatrics, blacks in the United States who've been prejudiced against for years, et cetera. So there's lots of folks that we can go to get help with. But I think the frail elderly actually aren't one of them. They tend, my guess is, to be a group that have been largely ignored in getting their input into what their research priorities are. So I frankly think you could be trailblazers and have a real opportunity here. Remember disadvantaged populations. You might say that a frail elderly with dementia might be a disadvantaged person in and of itself. But remember, the frail elderly with multiple comorbidities tend to be the underhoused, the poor, et cetera. So, you know, I think a thing that you really need to spend a lot of time thinking about is how do you reach those. And finally, I think for those of you who are researchers, which is most of you, I think, there's a real opportunity for methodological research on what's the best ways of doing this. And the PCORI, which is a patient-centered outcome research institute in the US, if you've not seen them, look them up. They're funding lots of stuff in this area. And I know Sharon Strauss at our place has just submitted a grant, which is actually a randomized trial of 3 different ways of engaging patients in setting research priorities. So I do think we need, you folks could be generating lots of terrific evidence about how to do this well and what works and what doesn't work in which circumstances.